Every single time you bite down on, say, a really tough piece of meat or crunch into a hard-boiled sweet, you are generating enough localized force to theoretically shatter human bone.
It is an immense amount of pressure, yeah.
Right. I mean, if you're listening to this right now, just gently clench your jaw. Just feel that pressure for a second. Yet your jawbone doesn't snap, your teeth don't explode, and your brain isn't rattled into a concussion.
Which is quite lucky for all of us, frankly.
Very lucky. But how is that actually possible? Because usually, when we think about the human face, we think about expression. We think about the smile, the frown, raising an eyebrow.
The aesthetics, essentially.
Exactly. If you imagine the face as a car, the superficial layers, the skin, those delicate expressive muscles around the eyes, the parotid gland, that's all the beautiful expressive bodywork. It's what everyone sees. But today, for this deep dive, we are lifting the bonnet. We're going right underneath the bodywork.
Because we are bypassing the aesthetics entirely today and delving straight into the machinery. The face is, well, it's not just a canvas for emotion. It is a heavy-duty mechanical processor.
Yeah, we are entering the deep face. So if the superficial face is the bodywork, the deep face is the engine room. It's hidden away, buried deep beneath the mandible, your lower jawbone, and the zygomatic arch, which is that bony bridge of your cheek.
Right, and down there, the face essentially stops expressing and starts working.
This is where force is forged. It's where this incredibly complex motion is orchestrated. And it's where the quiet, incredibly powerful machinery of mastication, of chewing, comes to life.
And really, that functional shift is the entire premise of our analysis today. Because anatomy, especially for anyone listening who's studying medicine, dentistry, or surgery anatomy, is never just a static list of Latin names.
Right, it's not just memorizing a map.
Exactly. It is the study of structure in service of function. How is this machine built? And more importantly, why is it built that way? Because in the deep face, that structural architecture dictates how diseases spread.
Yeah.
It determines the exact angles a surgeon or a dentist has to use for an intervention, and it ultimately shapes the patient's outcome.
So our mission today, using the textbook of head and neck anatomy as our sort of foundational guide, is to build a spatial and functional mental model of this engine room.
Spot on.
Okay, well, let's unpack this, because to understand an engine room, I feel like you first have to know where the walls are.
You need the boundaries, yeah.
Right. So if I am visualizing the human skull, or, even just feeling my own head right now, where exactly is the deep face? How do we define its physical boundaries?
To map the deep face, we really need to delineate two primary interconnected spaces. And those are the temporal fossa and the infratemporal fossa.
Okay, two spaces.
Right. Let's build the upper room first, which is the temporal fossa. If you place your fingers on the side of your head, just above your ear, and slightly forward right on your temple, basically you are touching the outer boundary of the temporal fossa.
I'm actually doing that right now.
It is essentially a wide, shallow bowl on the side of the cranium.
Right, and if I trace my fingers upwards from my ear, just feeling the side of my skull, I can feel this very faint sort of curved ridge on the bone, right before my head starts to curve over the top.
Yes. That ridge is the superior temporal line. It arcs right across the side of the skull, and it serves as the upper boundary or the ceiling of the temporal fossa.
Okay, so that's the ceiling. What about the floor?
Well, the floor of this shallow bowl is actually quite a mosaic. It's made up of portions of 4 different cranial bones meeting together. You've got the frontal, the sphenoid, the temporal, and the parietal bones.
So a real jigsaw puzzle.
Very much so. Now, as you move your fingers back down the side of your head, sliding past your temple, you will hit a very prominent horizontal bony bridge.
Right, the cheekbone. It feels like a solid bar of bone sitting right above my jaw.
Anatomically, that is the zygomatic arch. And for the temporal fossa, that arch acts as an arbitrary inferior boundary. It's the floor of that upper room.
Got it.
But the contents of the temporal fossa, specifically the massive muscle that lives in there, they do not just stop at that bony bridge, they dive down beneath it.
Oh, I see.
Yeah. And once you pass beneath that zygomatic arch and go deep to the vertical part of the jawbone, you have entered the true hidden cavern. You have entered the infratemporal fossa.
So just to make sure I have this spatial model right in my head, the temporal fossa is the shallow, wide bowl on the upper side of the head.
Correct.
And the infratemporal fossa is the deeper, darker cave located directly beneath it, sort of hidden securely behind the jawbone.
That is the perfect architectural model, yes.
Yeah.
And unlike the smooth, shallow bowl above it, This lower cavern has highly complex, very irregular walls.
Irregular how?
Well, think of it as a room where every single wall serves a specific mechanical purpose. The anterior wall, the front of the cave, is formed by the posterior aspect of the maxilla, which is your upper jawbone.
Okay, the upper jaw is the front wall.
Right. Then the lateral wall, the outside boundary protecting the cave from the external world, is the ramus and the coronoid process of the mandible.
So the lower jawbone itself acts as the outer shield of this space. It's almost like an armored door.
It is an armored door, absolutely. Now, if we move inward, the medial wall, so the deepest boundary, closest to the center of the head, is formed by a specific structure called the lateral pterygoid plate of the sphenoid bone.
I have to admit, I always struggle to visualize the sphenoid bone.
Most people do. It's notoriously difficult.
Right. Because when you see it isolated in a textbook, it looks like a bizarre jagged bat or a butterfly that's just wedged right into the dead center of the skull behind the eyes.
It is a brilliantly complex bone because it acts as the central keystone of the cranium. So if you imagine that bat shape you described, the legs of the bat extending downwards are the pterygoid processes.
Okay, I'm picturing the bat legs.
Right, and one of those bony legs, the lateral pterygoid plate, drops down to serve as the inner wall of our engine room.
That makes perfect sense.
And finally, the roof of this cavern is formed by the underside of the wing of that same bat. Anatomically, that's the infratemporal surface of the greater wing of the sphenoid bone.
Okay, so we have the walls sorted, the upper jaw in the front, the lower jaw on the outside, the sphenoid bat legs on the inside, and the sphenoid wing acting as the roof.
Exactly.
But, looking through the textbook, there's a massive amount of ink dedicated to the fascia in this region.
Oh, yes. The fascial layers are critical.
You've got the temporal fascia, the masseteric fascia, the pterygoid fascia. And I have to push back here for a second.
Go ahead.
To a layperson or even an early medical student trying to learn this, fascia just sounds like anatomical packing peanuts.
Packing peanuts.
Yeah. It just seems like the slippery, inert white stuff that fills the empty space between the important things, the muscles and the bones. So why does this specific wrapping matter so much? Like, if I'm a surgeon, why do I care about biological cling film?
That is a very common and honestly potentially dangerous misconception. Fascia is definitely not packing material, and it's certainly not flimsy cling film.
Fair enough.
In the context of the deep face, this fascia is a highly engineered, heavily reinforced containment unit. We are talking about deep cervical fascia here. It is thick, it's tough, and it's incredibly unyielding.
So it doesn't stretch at all?
Barely. It completely surrounds the muscles of mastication and encircles the ramus of the mandible.
Yeah.
And in doing so, it creates a sealed, isolated, and highly pressurized chamber.
A containment unit. So is the goal to keep things in or to keep things out? Like, what is it actually containing?
Well, it serves both purposes, but mechanically it is all about directing force. Let's trace how it forms this unit. Cranially, it attaches firmly to the zygomatic arch.
A cheekbone.
Yes. From that bony anchor, it splits. One tough layer goes down over the outer surface of the masseter muscle. This is the masseteric fascia. It also splits to completely encapsulate the parotid gland, which we term the parotidiomasseteric fascia. Then it travels all the way down and completely encircles the inferior border, the bottom edge of the mandible.
Wait, it literally wraps underneath the jawbone like a sling.
It does. It cradles it.
Yeah.
And once it wraps around the bottom edge of the mandible, it travels back up on the inside of the jaw.
Oh, I see.
Here, it is known as the pterygoid fascia, and it encloses the deep muscles. Then, at the superior border, where the temporal muscle originates from the skull, these layers fuse together again.
Wait, so you have essentially shrink-wrapped the entire jawbone and all the massive muscles attached to it into one continuous, impenetrable envelope.
You have. And that envelope creates what anatomists and clinicians call the masticator space.
The masticator space.
Yes. Inside this sealed room, you have the four primary muscles of mastication, the vertical ramus of the mandible, the major nerves, the main artery, and a significant portion of something called the buccal fat pad.
All packed in there.
All packed in. And because this envelope is made of deep fascia, it is rigid. As we said, it does not stretch.
Okay, but this is what I don't get. Why does a muscle need to be shrink-wrapped in a rigid envelope? Doesn't a muscle need space to expand when it flexes?
That's a great question. Think about the physics of a hydraulic press.
Okay.
If you have a cylinder of fluid and you apply pressure, you want all that force directed linearly, right?
Straight down or straight up?
Exactly. If the walls of that cylinder are made of rubber, they will bulge outward, and you lose your mechanical force.
Oh, I see where you're going with this.
The muscles of mastication generate hundreds of pounds of force. If they weren't tightly contained by this unyielding fascia, they would simply bulge outward,
Wasting energy.
wasting energy and severely distorting the face. The fascia forces the muscle to direct all its contractile energy longitudinally, pulling the jaw shut with maximum efficiency.
That is brilliant.
Furthermore, the fascia here does not just wrap, it actually thickens in specific areas to form critical structural ligaments.
Ligaments. So the wrapper itself turns into the structural support cables.
Exactly that. It's multifunctional. For instance, as the pterygoid fascia reflects over the medial pterygoid muscle and attaches upward to a sharp bony point called the spine of the sphenoid, it thickens dramatically.
Okay.
This thickened band then drops down to attach to the lingula of the mandible.
Let me stop you there. The lingula. I don't know that term.
Ah, right. If you were to look at the inner surface of the lower jawbone, near the hole where the nerves enter, there is a tiny, sharp, tongue-like projection of bone.
Oh, okay.
Lingular is actually Latin for little tongue. So this fascial thickening forms the sphenomandibular ligament, which acts as a crucial suspensory cable. It is literally hanging the jaw from the skull.
Wow.
And another thickening between the pterygoid muscles forms the pterygospinous ligament. So this packing peanut material you mentioned, it provides vital structural suspension. It is the rigid scaffolding of the engine room.
Okay, I officially take back the packing peanuts comment.
Yeah.
I am fully converted. It is the reinforced hull of the compartment, and it directs the mechanical force.
I'm glad you're convinced.
But this engine room isn't completely sealed off, right? I mean, an engine needs intake valves and exhaust pipes. The power has to get from the brain into this sealed room somehow. So how do things get in and out of the masticator space?
The infratemporal fossa is highly connected, but only through very specific, tightly regulated archways and doorways.
Okay.
If we look at the medial aspect of the roof, that greater wing of the sphenoid we discussed, there are two critical trapdoors leading directly into the cranial vault, right under the brain.
Trapdoors in the roof of the cavern.
Exactly. The larger of the two is the foramen ovale. Oval simply meaning oval-shaped.
Naturally.
This is the main gateway from the brain into the deep face. It transmits the massive mandibular division of the trigeminal nerve, which is the heavy wiring that controls the whole system. And right behind it, and slightly lateral, is a much smaller opening called the foramen spinosum, located near that spine of the sphenoid we just talked about.
And what goes through there?
This one transmits the middle meningeal artery upwards, out of the engine room and into the skull, to supply the coverings of the brain.
So the roof has two main holes, one bringing nerve commands down, one sending a blood vessel up.
Right.
What about the walls? How does this room connect to the rest of the face?
At the very front, superiorly, there is a gap between the upper jaw and the sphenoid bone. This is called the inferior orbital fissure.
Inferior orbital, so the eye.
Yes, as the name suggests, this is a doorway straight into the floor of the orbit, the eye socket. The maxillary division of the trigeminal nerve uses this path to reach the face.
Okay.
And then on the intermedial wall, there is a vertical cleft. It's a very narrow gap between the maxilla and the lateral pterygoid plate. This is the pterygomaxillary fissure.
A fissure. That sounds like an incredibly tight squeeze for anything trying to get through.
It is a severe bottleneck. It connects the infratemporal fossa to a tiny, highly trafficked room even deeper inside the skull, called the pterygopalatine fossa.
Wow. Okay.
The major blood vessel of the deep face, the maxillary artery, has to weave through our engine room and squeeze through this pterygomaxillary fissure just to reach the nasal cavity and the upper teeth.
Okay, so if I'm picturing this whole space now, we have a heavily reinforced fascia-wrapped compartment sitting beneath the cheekbone and behind the jaw.
Yes.
It has trapdoors in the roof leading to the brain, a window in the front leading to the eye socket, and a narrow fissure on the inside leading deeper into the facial skeleton.
That is a perfect summary.
Right. So that is our physical engine room. Now let's talk about the engines themselves, the pistons, the muscles of mastication.
Absolutely. There are 4 primary muscles of mastication. And when we talk about their origins, the textbook makes a specific point to classify them based on their embryological development.
Okay.
They all arise from the first pharyngeal arch mesoderm.
Whoa, let's translate that. First pharyngeal arch mesoderm sounds like a spell from Harry Potter.
It does a bit.
To a medical student just trying to learn the muscles, what does that actually mean? Why should we care where they came from as a tiny embryo?
Because it's a vital concept. Embryology dictates wiring.
Oh, interesting.
In the developing embryo, The first pharyngeal arch is the block of primitive tissue that eventually forms the jaw and the chewing apparatus. Because all four of these muscles are born from that exact same block of tissue, they are essentially biological siblings. They must share the exact same nerve supply.
Ah, I see.
You will never find a muscle of mastication innervated by the facial nerve or the vagus nerve. Because of their shared origin, they are all exclusively wired to the mandibular division of the trigeminal nerve.
So it makes remembering their innervation incredibly logical rather than just rote memorization.
Precisely. Once you know the embryology, you don't have to memorize it blindly.
That makes perfect sense. They grew up in the same house, so they share the same electrical grid.
I like that analogy.
So we group these four muscles based on what they mechanically do, right? You have the heavy lifters, the elevators that slam the jaw shut, and the one oddball that pulls it open. Let's start with the heavy lifters. The first one is the temporalis.
Temporalis is magnificent. It is a massive fan-shaped muscle that completely fills that upper room we defined, the temporal fossa.
Right.
Its origin is incredibly broad. It attaches all along that superior temporal line and sweeps across the entire side of the skull.
It's like pulling a drawbridge up from a really wide distributed anchor. You have this massive sweeping fan of muscle on the side of your head, and all of those thousands of muscle fibers converge down into a single, highly concentrated, powerful tendon.
Exactly. And that tendon passes deep beneath the zygomatic arch and inserts onto the coronoid process of the mandible.
The coronoid process, if I recall the shape of the jawbone, that's the piece of bone sticking up at the front of the hinge that looks almost like a shark fin.
Yes, the shark fin is a great way to picture it.
So the temporalis tendon grabs onto that fin and just yanks it upwards.
It does. It is primarily a powerful elevator of the mandible. It pulls the jaw shut.
Yeah.
But here is where the anatomy dictates a highly nuanced function.
Nuanced how?
Because of its broad, sweeping fan shape, the muscle fibers are aligned in completely different vectors.
Oh, because they're spread out.
Right. The anterior fibers, the ones near your forehead, they run almost perfectly vertically.
Yeah.
When they contract, they pull straight up.
Closing the jaw with a straight upward force.
Yes, but the posterior fibers, the ones wrapping around towards the back of your ear, they run in an almost horizontal plane.
Oh, so they pull differently.
Yes. When those posterior fibers contract, they do not pull up, they pull backwards. They act to retract the mandible.
Okay, so if I jut my lower jaw forward right now, like an underbite position, it is the back part of the temporalis muscle that I have to fire to pull it back into a normal resting position.
Exactly right.
That is brilliant biomechanics in one single muscle. Okay, so that is our first elevator. The second heavy lifter is the masseter, and this is the one that sits outside the deep face compartment, right?
Well, it sits within the fascial envelope, but lateral to the bone itself.
Right.
The masseter lies on the outside of the mandible.
Right, okay.
It is the muscle that gives the back of the jaw its squared quadrangular shape. It is an absolute powerhouse of a muscle. It originates on the zygomatic arch, the cheekbone, and inserts broadly over the outer lateral surface of the ramus and the angle of the jaw.
If you clench your teeth really hard right now and feel that thick muscle bulging on the side of your jaw, that is the masseter. It feels like a solid block of wood.
It is remarkably dense.
Yeah.
And the masseter is actually divided into two distinct functional bellies, a superficial portion and a deep portion.
Oh, really?
Yes. The superficial portion arises via a thick, tendinous aponeurosis from the front two-thirds of the cheekbone. Its fibers run diagonally downwards and backwards.
Down and back.
And this diagonal orientation is critical. It allows the muscle to direct an incredibly powerful force directly onto the molar teeth for crushing.
Pure, brute crushing force right where you need it, on the flat, grinding teeth. But wait, why two bellies? Why not just one massive block of muscle?
Because mastication requires fine-tuning, not just brute force. The deep portion of the masseter originates from the back third of the zygomatic arch and from its inner medial surface. These deep fibers run much more vertically.
Ah, I see.
So while the superficial fibers provide the diagonal crushing force, the deep fibers affect a retractive force, helping to pull the jaw vertically up and slightly back during closure, working synergistically with the posterior temporalis we just discussed.
That coordination is incredible. There's also a detail I caught in the text about the masseter and the temporalis interacting. It used the term zygomatico-mandibularis Did I read correctly that these two separate muscles actually melt into one another?
You read that perfectly correctly, and it is a fascinating area of functional anatomy. At the very top of the jaw insertion, near the base of that shark fin coronoid process,
Right.
the deep fibers of the masseter often blend and fuse directly with the descending fibers of the temporalis muscle.
They just merge.
They do. This fused muscular complex is termed the zygomatico-mandibularis muscle. It is a powerful reminder that while we separate these structures in textbooks to pass exams in the living body, these muscles act as a coordinated continuum. They share the workload.
Okay, so we have the temporalis pulling the drawbridge up, and the masseters acting like a powerful hydraulic press on the outside of the jaw. But from a sort of orthopedic perspective, you cannot just pull a complex hinge joint from one side.
No, you cannot.
You need balance. If you only pulled from the outside, you would surely dislocate the jaw over time.
Which brings us beautifully to the internal counterpart of the masseter, the medial pterygoid muscle.
The internal masseter.
The medial pterygoid is the deepest of the masticatory muscles. It originates deeply within the skull from the pterygoid fossa and the inner surface of that lateral pterygoid plate of the sphenoid we identified earlier as the inner wall of our room.
So it's anchored to the deepest, most medial wall of our engine room.
From that deep medial anchor, its fibers course downwards, backwards, and outwards so posteriorly and laterally to insert onto the inner aspect of the angle of the mandible.
Wait, let me map those vectors in my head. Downwards, backwards, and outwards. That is almost the exact same path the masseter takes. It's just on the inside of the bone instead of the outside.
It is the exact mirror image.
Yeah.
And this is where the biomechanics of the deep face become truly beautiful. The masseter wraps around the outside of the angle of the jaw. The medial pterygoid wraps around the inside of the angle.
Oh, wow.
Occasionally, their tendinous fibers even meet underneath the bone, forming a tendinous inscription called a pterygomasseteric sling.
A sling, so they are quite literally cradling the bottom of the jaw in a muscular hammock.
They suspend the angle of the mandible in a synergistic hammock between them. When they contract together, they elevate the jaw with immense, perfectly balanced force.
That is so elegant.
By pulling from both the inside and the outside simultaneously, the horizontal forces cancel each other out. This means all the generated energy translates into pure vertical elevation. It utilizes the temporomandibular joint, the TMJ, simply as a guide track rather than forcing it to act as a load-bearing fulcrum.
That makes perfect mechanical sense. If you only pulled from the outside with the masseter, you would torque the jawbone outwards and just destroy the joint.
Over time, yes, absolutely.
By pulling from the inside with the medial pterygoid at the exact same time, pure efficiency is achieved.
Yeah.
Okay, so we have three massive muscles, the temporalis, the masseter, and the medial pterygoid, all dedicated to forcefully slamming the jaw shut.
Heavy lifters.
Now we arrive at the odd one out, the lateral pterygoid muscle. If three of these muscles are built to forcefully slam the jaw shut, why is this one muscle trying to open it?
Because opening the human jaw is not just a simple matter of relaxing the elevators and letting gravity pull your mouth open.
Right, gravity is a bit slow.
Gravity is far too slow and uncontrolled for speech or rapid chewing. The lateral pterygoid is indeed the classic jaw opener, but its mechanics are highly sophisticated. It is a short, thick muscle that essentially fills the rest of the infratemporal fossa, sitting horizontally right over the medial pterygoid.
Okay.
And it is composed of two completely distinct heads, a superior head and an inferior head.
Two heads doing two different things.
Yes. And modern anatomical evidence suggests they function so antagonistically that they could almost be considered separate muscles entirely.
Really?
Yes. The smaller superior head originates from the roof of the fossa, the infratemporal crest of the sphenoid. Its fibers run horizontally backwards and insert directly into the articular capsule of the TMJ itself, including the anterior border of the articular disc.
Wait, it inserts into the joint disc? Not just the bone. That seems highly unusual.
It is highly specialized. Its primary role is not moving the jaw, but acting as a dynamic stabilizer.
How does that work?
When you bite down hard, generating crushing force with your masseter, the superior head of the lateral pterygoid tenses. It pulls the fibrocartilage articular disc forward to brace it against the condyle of the mandible. This prevents the joint from dislocating backwards under the immense pressure.
That is the stabilizer. Okay. What about the inferior head?
The larger inferior head originates from the lateral surface of the lateral pterygoid plate. Its fibers also run backwards and outwards, but they insert onto the anterior surface of the neck of the mandible just below the joint itself.
So when this inferior head contracts, it pulls the neck of the jawbone forwards.
It pulls the mandible and the articular disc forwards and downwards, sliding them down the bony slope of the skull called the articular eminence.
Right.
This forward translation is what physically initiates the opening of the jaw. And here's where it gets critical for chewing. If only one side contracts unilateral function, it pulls the jaw across to the opposite side. This creates the side-to-side grinding motion essential for breaking down food.
So the lateral pterygoid is the fine-tuner. It protrudes the jaw, it swings it side to side, and it pulls it forward to open it, while the superior head desperately holds the joint together under pressure.
Exactly. It's a marvel.
That is an incredible piece of engineering. Now, before we move away from the muscles entirely, I was reading through the newer edition of the textbook, and it mentioned a muscle called the sphenomandibularus.
Ah, yes.
Is this a typo? Are we still discovering new muscles in the human head?
It is not a typo.
Yeah.
And it is a remarkable testament to the fact that gross anatomy is not entirely a closed, static book. For centuries, the sphenomandibularus was dismissed by anatomists as simply being a deep, aberrant slip of the temporalis muscle. Just an anomaly.
But it's not.
No. Careful, modern, three-dimensional dissections have demonstrated that it is a distinct, separate muscular entity with its own fascia.
Where does it hide?
It originates from the infratemporal surface of the greater wing of the sphenoid, very close to the superior head of the lateral pterygoid. And it descends vertically to have a distinct tendinous insertion onto the temporal crest of the mandible.
Do we know what it actually does yet?
Its exact biomechanical function is still being mapped out in the literature. Its vascular supply comes from small branches of the maxillary artery, shared with the medial pterygoid. The specific nerve supply is actually still under investigation.
That's wild.
But its very presence reminds us that the deep face is an engine of staggering, layered complexity, and our mental models must remain open to refinement as imaging and dissection techniques improve.
I love that. The engine room still has secrets. So we have mapped the space, and we've analyzed the pistons. But an engine is useless without fuel lines and electrical wiring. Let's trace the blood supply and the nerve commands. We'll start with the fuel line, the maxillary artery.
The vascular supply to this entire region is dominated by the maxillary artery. It is the larger of the two terminal branches of the external carotid artery. It originates deep within the substance of the parotid gland, just behind the neck of the mandible. From there, it has to navigate through our highly congested, heavily pressurized engine room to supply the deep face, the nasal cavity, and the upper teeth.
Let's think about that functionally for a second. If you are a blood vessel, a soft, pliable tube, this engine room is an absolute nightmare.
A very hostile environment.
You have to dive into a tight space between the jawbone and the sphenomandibular ligament, surrounded by massive muscles generating hundreds of pounds of sheer force. How does the artery survive being crushed?
It survives through an incredibly tortuous winding path that allows for slack during movement and by embedding itself in the softer connective tissues between the muscle bellies. Anatomists conceptually divide the maxillary artery's perilous journey into 3 acts, or portions, based on its relationship to the lateral pterygoid muscle.
Okay, 3x.
The first act is the mandibular portion.
This is right as it dives behind the mandible, entering the room.
Yes, in this first segment, the artery is primarily concerned with feeding structures below and inside the cranial vault. It gives off the deep auricular and anterior tympanic arteries to supply the ear. But crucially, it gives off the middle meningeal and accessory meningeal arteries.
Ah, the ones that go straight up through the roof of our engine room, the foramen spinosum and foramen ovale we talked about earlier.
Exactly. They ascend through those bony trapdoors to vascularize the dura mater, the tough outer covering of the brain. Also in this first portion, the artery sends a major branch directly downwards, the inferior alveolar artery.
Where does that one go?
This vessel enters the mandibular foramen and travels through a tunnel inside the jawbone itself, supplying the bone, the lower teeth, and the supporting gums. And just before it enters the bone, it gives off the myloid artery to supply the muscular floor of the mouth.
So the first act is a distributor sending blood up to the brain, covering above and down to the jawbone below. What is the second act?
The second act is the pterygoid portion. This is the dedicated muscle feeder.
Fueling the pistons.
Exactly. As the artery weaves through the deep face, sometimes passing superficial to the lateral pterygoid muscle, sometimes weaving deep to it, it provides dedicated, high-pressure arterial branches to our pistons. It gives off the masseteric artery, which passes through the mandibular notch to feed the masseter.
Got it.
It gives off anterior and posterior deep temporal arteries that ascend to supply the temporalis. And it gives off short, muscular pterygoid arteries to both the medial and lateral pterygoids.
It is directly fueling all the heavy lifters. Now, there is also a branch here called the buccal artery, which the textbook notes goes to the buccinator muscle in the cheek.
Yes.
But the textbook also highlights a strange irony here. The buccal artery feeds the buccinator muscle, but the buccal nerve does not provide its motor function.
That is a classic anatomical trap for students.
Yeah.
The buccal artery vascularizes the buccinator muscle and the mucous membrane of the cheek. The buccal nerve, which travels right alongside it on the exact same highway, provides sensory innervation to the cheek. It lets you feel the inside of your mouth.
But it doesn't move the cheek.
No. The actual motor command to move the buccinator muscle comes from a completely different source, the facial nerve. It is a reminder that vessels and nerves may travel the exact same highways, but they serve completely different masters.
A vital piece of trivia for the exams right there. And the final act of the maxillary artery.
The third act is the pterygopalatine portion. The artery finally leaves our engine room by squeezing through that narrow medial cleft we discussed, the pterygomaxillary fissure, entering the tiny pterygopalatine fossa.
The bottleneck.
Right. Here, it acts as a terminal distribution hub. One of its first major branches here is the posterior superior alveolar artery.
The PSA artery.
It descends over the back of the upper jaw, the maxillary tuberosity, to enter the bone and supply the upper molar and premolar teeth, as well as the mucosal lining of the maxillary sinus. The rest of the artery continues on to supply the nasal cavity, the palate, and the floor of the orbit.
Okay, so that is the high-pressure fuel line pumping oxygenated blood in, but engines also need exhaust pipes. They need venous drainage to take the deoxygenated blood and metabolic waste away. And in the deep face, we do not just have a single neat vein returning to the heart. We have the pterygoid venous plexus.
You do.
When I read the description of this, I just imagined a massive, messy sponge of veins just wrapped around all the pterygoid muscles.
A sponge is an excellent visualization. It is a massive, intricate network of interconnecting venous channels lying on and around the surfaces of the medial and lateral pterygoid muscles. It collects venous blood from the muscles, the superficial face, the nasal cavity, and the orbit.
Okay.
But we must ask the functional question. Why a plexus? Why a diffuse sponge instead of a single rigid, efficient pipe?
Well, I assume it goes back to the pressure issue. If you had a single, large, rigid vein running through a sealed fascial compartment filled with massive, bulging muscles, it would just get pinched shut every single time you chewed.
That is exactly the fluid dynamic at play. Constant volume within a rigid fascial compartment requires a deformable venous system. Mastication involves intense, rapidly fluctuating pressures.
Right.
A single venous trunk would be easily and repeatedly occluded, leading to immediate severe pooling of blood and swelling. A plexus, a sponge, ensures that even if one area is violently compressed by a contracting pterygoid muscle, the blood simply reroutes instantly through a dozen collateral channels.
Amazing.
The drainage remains completely uninterrupted regardless of jaw position.
That is brilliant biological design, but this sponge is also highly connected to the inside of the skull, isn't it?
It is, and that is where its immense clinical danger lies. Veins in the head and neck, unlike veins in your legs, generally lack valves. Blood flow can reverse direction based entirely on pressure gradients.
No valves. That sounds risky.
Very. The pterygoid venous plexus has direct and indirect communications via emissary veins with the cavernous sinus. The cavernous sinus is a major venous reservoir located inside the cranial cavity right at the base of the brain.
So a fluid connection exists straight from the deep jaw into the brain case.
Yes.
We are definitely going to come back to why that matters when things go wrong in the clinical section. But first, we need to talk about the wiring, the command center. This engine does not run on its own.
All of this complex machinery is controlled by the mandibular division of the trigeminal nerve, also known as cranial nerve V3. The trigeminal nerve is a massive cranial nerve. It has three divisions: ophthalmic V1, maxillary V2, and mandibular V3.
Okay.
But the mandibular division is totally unique. It is the only division that contains both sensory and motor nerve fibers.
Wait, if the trigeminal nerve is so massive, why is only one division doing the actual heavy lifting of movement while the other two just feel things? That seems incredibly unbalanced.
It goes back to that embryology we discussed earlier, the first pharyngeal arch.
Oh, right.
V1 and V2 develop purely to provide sensory feedback from the face to the brain. But V3 is the dedicated nerve of the first pharyngeal arch. Because the muscles of mastication developed in that exact arch, V3 had to bring motor fibers along with it to plug into those specific muscles.
That makes sense.
The sensory and motor roots exit the skull separately through the foramen ovale and then they immediately unite into a short trunk within the infratemporal fossa. From this main trunk, the nerve quickly splits into two major divisions: an anterior division and a posterior division.
Okay, let's break those down. What does the anterior division do?
The anterior division is primarily motor. This is the heavy electrical wiring going directly to the pistons. It provides the masseteric nerve to the masseter, the deep temporal nerves to the temporalis, and the nerve to the lateral pterygoid.
It's the driver.
It is the driver of mastication. It does carry one single sensory branch, the buccal nerve we mentioned earlier, which goes to feel the cheek, but it's overwhelmingly a motor division.
And the posterior division.
The posterior division is the exact inverse. It is primarily sensory. It provides the sensation of touch, pain, and temperature to the lower jaw, the teeth, the tongue, and the skin of the lower face. It only has one small motor branch.
The mylohyoid nerve, right.
Correct. It branches off right before the main nerve enters the jawbone, and it goes down to supply the mylohyoid muscle on the floor of the mouth and the anterior belly of the digastric muscle.
But the sensory branches of this posterior division are where things get wild. The textbook details the paths of these nerves, and honestly, they behave like anatomical hitchhikers. They just jump onto whatever structure is heading in their general direction.
Hitchhiker is the perfect term. The deep face is an incredibly complex, crowded junction box, and nerves frequently piggyback on other structures to get where they need to go efficiently. Let us look at the auriculotemporal nerve as a prime example.
This one blew my mind when I read it. Tell them what this nerve does to the middle meningeal artery.
The auriculotemporal nerve arises from the posterior division of V3, but it often originates as two separate roots. These two roots physically encircle the middle meningeal artery, creating a literal neural loop or buttonhole around the blood vessel just before the artery ascends into the foramen spinosum.
Incredible.
Once past the artery, the two roots join together into a single nerve that travels backwards to supply sensation to the TMJ, the ear, and the temple.
It literally hugs the artery on its way out. Why? Is there a functional reason, or is it just an embryological quirk?
It is an artifact of how the vascular and nervous systems develop and migrate in a very crowded embryonic space. The artery forms first as a pillar. The nerve roots grow outwards around it, and they are forever locked in that embrace.
So cool.
But the auriculotemporal nerve is also a classic hitchhiker. As it passes backwards through the parotid gland, it carries postganglionic parasympathetic fibers that originally came from the glossopharyngeal nerve.
Whoa, let's translate that. Postganglionic parasympathetic fibers. You're saying this is the body's automatic rest and digest wiring, the wiring that tells glands to secrete just hitching a free ride, and from a completely different cranial nerve.
Precisely. Cranial nerve 9, the glossopharyngeal nerve, wants to tell the parotid gland to produce saliva. But it does not have a direct physical route through the face to get there. So its fibers travel to a relay station called the oda ganglion.
Right.
From there, they jump onto the auriculotemporal nerve, which is conveniently passing right through the parotid gland anyway. The auriculotemporal nerve acts as a public bus for these secretory fibers.
That is anatomical carpooling. Does this happen anywhere else in the deep face?
It does. Look at the lingual nerve. It descends from the posterior division of V3 to provide general sensation, touch, pain, temperature to the anterior two-thirds of the tongue. But while it is traveling downwards through the deep face, under the cover of the lateral pterygoid muscle, it is joined by the chorda tympani nerve.
And the chorda tympani is a branch of the facial nerve, completely unrelated to V3.
Exactly. The facial nerve carries special sensory fibers for taste and parasympathetic fibers to make the submandibular and sublingual glands produce saliva. The chorda tympani emerges from the skull into the deep face, finds the lingual nerve, and physically merges with it.
Just joins the highway.
Exactly. The lingual nerve becomes the highway that carries the facial nerve's fibers the rest of the way to the tongue and the floor of the mouth.
It is spectacular efficiency. Instead of building 3 different highways to the mouth, the body just routes all the traffic onto one major interstate. And the final major branch of the posterior division is the inferior alveolar nerve.
The inferior alveolar nerve courses downward, passes between the sphenomandibular ligament and the ramus of the jaw, and enters the mandibular canal. It acts as the primary sensory wire for all the lower teeth and the supporting gums. Finally, a terminal branch, the mental nerve, pops out of the mentor foramen on the front of the jaw to provide sensation to the chin and lower lip.
And just to be completely thorough, the textbook mentions that the maxillary division, the second branch of the trigeminal, V2, makes a tiny cameo in the deep face.
It does. As the maxillary nerve passes through the pterygopalatine fossa, it sends a small branch laterally out into our engine room. This is the posterior superior alveolar nerve. It descends over the back of the upper jaw to enter the bone alongside its namesake artery, providing sensation to the upper molar teeth and the maxillary sinus.
So let's pause and consolidate this. We have this incredibly dense, sealed compartment. It is packed with heavy-duty muscles capable of generating hundreds of pounds of force. It is flooded with a high-pressure arterial supply, drained by a valveless, highly deformable venous sponge, and wired with a complex carpooling nervous system.
A busy room.
So what happens when this engine knocks? Let's move into the clinical correlations. How does this structural architecture shape disease?
This is where understanding the three-dimensional anatomy becomes critical for patient survival. Let us return to the fascia we debated earlier. We established that the deep cervical fascia creates a sealed, unyielding envelope around the deep face, the masticator space.
Right. It wraps the jaw and the muscles tightly to direct mechanical force.
Now imagine a patient develops a severe, untreated bacterial infection in a lower molar tooth. If that infection spreads beyond the tooth root and breaks through the cortical bone of the jaw, it can enter this masticator space.
Oh, no.
Because the fascia is tough and unyielding, the infection becomes trapped. It cannot swell outward to the skin easily.
So it becomes a biological pressure cooker.
A very dangerous one. The pressure builds rapidly within the compartment. The pus and intense inflammation violently irritate the medial pterygoid and masseter muscles, throwing them into severe involuntary spasm. The patient presents with profound trismus, meaning they physically cannot open their mouth no matter how hard they try.
Wow.
This locked jaw is a hallmark clinical sign of a masticator space infection.
And because the pressure cannot go out through the thick fascia, where does it go? Path of least resistance, right?
That is the ultimate danger. The masticator space communicates superiorly with the temporal fossa, but far more worryingly, it communicates medially and posteriorly with the deep spaces of the neck, such as the parapharyngeal space.
Down into the neck.
If the purulent infection tracks down those fascial planes, guided by the very fascia meant to protect the face, it can rapidly compromise the patient's airway, leading to asphyxiation. Or it can descend all the way down into the mediastinum, the chest cavity containing the heart.
That's terrifying.
A masticator space infection is a medical emergency requiring rapid surgical drainage and intravenous antibiotics. The rigid anatomy dictates the severity.
The walls of the engine room become a deadly trap. And what about that venous sponge, the pterygoid venous plexus? You mentioned it communicates with the cavernous sinus in the base of the brain and that it lacks valves. How does that cause problems clinically?
It is a critical daily concern in clinical dentistry. When a dentist needs to numb an upper molar tooth for a filling or extraction, they perform a posterior superior alveolar, or PSA, nerve block. They advance a needle high up behind the maxillary tuberosity, right into the anterior portion of the infratemporal fossa, targeting that small V2 nerve branch we just discussed.
They are essentially flying blind into the engine room, pushing a needle into a space they cannot see.
They rely entirely on tactile feedback and anatomical landmarks. But remember, the pterygoid venous plexus is draped all over this exact area like a sponge. If the needle angle is incorrect, or if the needle is inserted too deeply, it can easily puncture this venous sponge.
And because it is a low-pressure sponge, it bleeds instantly.
It bleeds significantly into the loose tissue spaces of the deep face, creating a rapid, noticeable hematoma, a large, swelling internal bruise that pushes the cheek out.
Not ideal.
While a hematoma is distressing and uncomfortable for the patient, it will eventually resolve. The far more terrifying risk is infection. If the needle was contaminated, or if it carried bacteria from the patient's mouth into the deep tissue, the needle tract can introduce bacteria directly into the venous plexus.
And because there are no valves to stop backward flow,
the bacteria can travel backwards along the pressure gradient through the emissary veins, straight through the skull base, and into the cavernous sinus. This results in cavernous sinus thrombosis, a devastating and historically fatal intracranial infection that can cause blindness, cranial nerve palsies, and death.
just from a dental injection.
The anatomy provides a direct, valveless highway from a simple dental injection straight to the brain.
That is deeply sobering. The engine room has a direct exhaust vent to the control room. Okay, let's shift to the mechanical side of things. The TMJ, the temporomandibular joint, this is the physical hinge of the engine. Temporomandibular disorder, or TMD. I know so many people who suffer from this. Clicking, grinding, chronic pain. Why is this joint so prone to failure?
The TMJ is arguably the most complex joint in the human body. Think about its mechanical demands. It is a bilateral joint. Both the left and right sides must move in perfect simultaneous synchrony. You cannot move one TMJ without moving the other.
Right. because it's one solid bone.
Furthermore, it is the only joint in the body that has a rigid bone, the mandible, spanning between the two articulations. And most uniquely, the teeth dictate the final closure position of the joint, not just the ligaments and bone.
So if the teeth do not align perfectly, a malocclusion, the joint is violently forced to compromise its ideal anatomical position every single time you bite down.
Precisely. TMD is a manifestation of the engine machinery malfunctioning under stress. It can be caused by bruxism, chronic grinding of the teeth, or clenching during periods of psychological stress. This chronically overworks the muscles of mastication. The lateral pterygoid, in particular, goes into a state of hypertonic spasm.
And remember, we established earlier that the superior head of the lateral pterygoid is attached directly to the articular disc inside the joint.
Exactly. If that muscle is in chronic spasm, it constantly pulls the fibrocartilage disc forward out of its ideal alignment between the condyle and the skull. When the patient opens their mouth, the condyle of the jawbone physically pops over the misaligned, bunched-up disc, causing that loud clicking or grinding noise.
Ouch.
Chronic imbalance leads to severe inflammation of the joint capsule, referred pain throughout the side of the head, and an inability to fully open or close the jaw. Treating TMD is notoriously difficult because it requires addressing the whole interconnected system, the muscles, the teeth, the psychological stress, and the joint itself, because they are inextricably linked anatomically.
Okay, let's look at one more clinical scenario. What if the command center itself is damaged? What happens in a trigeminal nerve injury? Let us say the mandibular division, V3, is completely severed due to massive facial trauma, like a severe jaw fracture from a car accident.
A V3 severing injury provides a stark, living demonstration of muscle antagonism. Let's assume the right V3 is severed. The anterior division is dead, meaning the motor commands to the right masseter, right temporalis, and right lateral pterygoid are entirely gone. The muscles on that side are paralyzed and will eventually atrophy.
So that side of the jaw just hangs loosely there.
Not quite. The jaw actually deviates forcefully towards the paralyzed side when the patient tries to open their mouth.
Wait, let me logic this out. It moves toward the broken side. Why?
Think about the physics of the lateral pterygoids. They are the openers. When a healthy person opens their jaw, both the left and right lateral pterygoids contract simultaneously, pulling both sides of the jaw forward equally, so the chin drops straight down in the midline.
Okay, I see it. If the right nerve is severed, the right lateral pterygoid is dead. It does not pull forward at all. It acts as a dead, fixed pivot point.
Right. But the left lateral pterygoid is still completely healthy.
Yeah.
When the patient tries to open their mouth, the left muscle contracts and pushes the left side of the jaw forward. Because the right side is acting as a dead pivot, the forward push from the left swings the entire chin over to the right, towards the paralyzed side.
That is fascinating physics. The healthy muscle pushes the jaw into the dead space.
Yes. And concurrently, because the posterior division is also severed, the patient suffers profound sensory loss. Complete numbness over the chin, the lower lip, the buccal mucosa inside the cheek, all the lower teeth on that side, and the anterior two-thirds of the tongue on the affected side. The engine on that side is completely offline, both mechanically and sensorially.
Okay, we have looked at the static spaces, the wiring, the fuel lines, and what happens when it breaks down. For our final section, I want to bring all of this together. I want to put the engine into dynamic motion, the symphony of mastication.
Mastication is far more than just opening and closing a hinge. It is not a simple up and down motion. It is a highly dynamic, multi-directional grinding process. It requires the instantaneous, perfectly coordinated firing of dozens of muscle slips in a precise sequence.
Right, because you don't just bite straight up and down. To chew something tough, like a piece of steak, you have to move the jaw side to side, grinding the flat surfaces of the molar teeth across each other to shear the fibers.
Exactly. Let's walk through the sequence. You ingest the food, and the muscles of the cheek and tongue. The buccinator and the intrinsic tongue muscles work together to position the bolus of food perfectly over the occlusal surfaces of the premolars and molars.
Yeah.
Then the powerful elevators engage. The masseter and medial pterygoid provide the vertical crushing force.
And the lateral pterygoid is firing on one side to swing the jaw across, creating the grinding shear force while the temporalis pulls it back.
Yes, and what is most fascinating neurologically is how this transitions from a conscious act to a semi-automatic rhythm. You consciously decide to take a bite of an apple, but you do not consciously calculate the exact micro-contractions of 50 different muscle slips to chew it 30 times. you would exhaust your brain's processing power.
Absolutely.
Instead, the brain hands the rhythmic control over to semi-automatic neural circuitry in the brainstem, often called a central pattern generator.
It is like setting cruise control on a highway. But what if something goes wrong? What if there's a rogue piece of bone hidden inside a hamburger? If these muscles are generating hundreds of pounds of force on cruise control, you would shatter your own teeth instantly before your conscious brain even registered the mistake.
This is where the biological collision sensors come into play. The entire system relies heavily on proprioception, the body's ability to subconsciously sense its position and the forces acting upon it. The periodontal ligaments, the tiny microscopic fibers that suspend the teeth in their bony sockets, are packed with highly sensitive mechanoreceptors.
So the teeth aren't just dead blocks of calcium, they are highly tuned sensory probes.
Absolutely. The moment your teeth sense something unexpectedly hard, a sudden spike in pressure, those receptors in the periodontal ligament fire a distress signal. It travels via the trigeminal nerve at lightning speed to the gray matter of the brainstem. The reflex arc immediately and involuntarily inhibits the motor neurons of the masseter and temporalis and simultaneously activates the jaw depressors.
It is exactly like traction control on a car. The moment your wheels start to slip, the computer cuts the throttle. The moment your teeth sense a bone, the system cuts the power to the masseter to stop you from shattering your own teeth.
A perfect functional analogy. It is an inhibitory reflex that is so incredibly fast, it interrupts the central pattern generator mid-cycle. The anatomy of the deep face is built not just to generate immense force, but to modulate it flawlessly to preserve the structural integrity of the stomatognathous system.
The stomatognatic system, the mouth, the jaws, the teeth, the muscles, the joints, all working as one unified, highly intelligent machine. This has been an incredible deep dive. Let's recap our key takeaways for everyone listening to consolidate this mental model. The deep face is the functional core of mastication. It is physically defined by the temporal and infratemporal fossa, walled in by the mandible on the outside and the sphenoid on the inside.
It is structurally contained by deep cervical fascia and powered by the four muscles of mastication: the temporalis, masseter, and medial pterygoid elevating the jaw, and the lateral pterygoid initiating opening and lateral movement.
It is supplied by the highly tortuous 3-acts of the maxillary artery and drained by the dangerous valveless pterygoid venous plexus.
And the entire complex is orchestrated by the unique mandibular division of the trigeminal nerve, V3, acting as the sole provider of motor commands while simultaneously gathering crucial sensory data from the lower face and teeth.
Before we move to the final review questions, do you have a final thought for us? Something that builds on all this anatomy and leaves us with a broader perspective to mull over.
Consider the evolutionary trajectory of the deep face. Millions of years ago, our early hominid ancestors survived on raw, tough, highly fibrous diets, roots, raw meat, uncracked nuts. They required absolutely massive muscles of mastication to survive. They had huge temporal fossae, prominent sagittal crests on top of their skulls just to provide enough bone for muscle attachment, and incredibly wide, flaring zygomatic arches to accommodate gigantic masseter muscles.
They were essentially built for pure, unadulterated crushing power.
They were. But as human ancestors discovered fire and began cooking food, our diet softened drastically. The biological demand for that extreme crushing power decreased. Over millennia, evolutionary pressures shifted. Energy was diverted to growing larger brains instead of larger jaw muscles. Our jaw shrank. The mandible became smaller, the face flattened, and the engine room of the deep face became much more compact.
But wait, if the jaw shrank so dramatically, did our teeth shrink too, or lose numbers?
That is the crux of the issue, and it is a fascinating evolutionary mismatch. While the bony dimensions of the jaw shrank quite rapidly in evolutionary terms, the ancient genetic code dictating the size and number of teeth did not adapt at the same pace. We still developed the exact same 32 teeth as our heavy-jawed ancestors, but we are now trying to fit them into a significantly smaller engine room.
Which perfectly explains the modern curse of impacted wisdom teeth. The third molars simply do not have the physical real estate to erupt properly into the mouth.
Precisely. The deep face is an anatomical landscape caught in an evolutionary lag. The parts list remained exactly the same, but the housing was heavily downsized. It is a beautiful, sometimes painful reminder that our anatomy is not just a static textbook diagram. It is a historical living record of our species' adaptation to the environment over millions of years.
The engine room is shrinking, but it is still running smoothly. I love that perspective. Okay, it is time to formally present the learning reinforcement segment. We have 6 single best answer questions to test your spatial and functional mental models based on what we've covered today. Question 1. Which muscle of mastication is primarily responsible for initiating the opening of the jaw? Is it A, masseter, B, temporalis, C, medial pterygoid, or D, lateral pterygoid?
The correct answer is D, the lateral pterygoid. While the masseter, temporalis, and medial pterygoid are all powerful elevators built to close the jaw, the inferior head of the lateral pterygoid pulls the neck of the mandible forward and down the articular eminence, initiating the opening sequence.
Question 2. During its path through the deep face, which nerve splits into two roots to encircle the middle meningeal artery? Options are A, buccal nerve, B, auriculotemporal nerve, C, lingual nerve, or D, inferior alveolar nerve.
The correct answer is B, the auriculotemporal nerve. This sensory branch arises from the posterior division of V3. In a classic display of anatomical hitchhiking and spatial crowding, it forms a neural loop entirely around the middle meningeal artery, just before the artery ascends to enter the foramen spinosum.
Question 3. An infection in the pterygoid venous plexus can spread directly into the cranial vault via its communication with which structure? A, cavernous sinus, B, sigmoid sinus, C, straight sinus, or D, superior sagittal sinus?
The correct answer is A, the cavernous sinus. The valveless, sponge-like pterygoid venous plexus connects various venous tributaries and has direct, dangerous communication with the cavernous sinus at the base of the brain. This creates a pathway where facial or dental infections can ascend and cause fatal intracranial complications.
Question 4. The sphenomandibular ligament is formed by a structural thickening of which fascial layer? Options: A, temporal fascia, B, masseteric fascia, C, pterygoid fascia, or D, parotidiomasseteric fascia?
The correct answer is C, the pterygoid fascia. As the pterygoid fascia reflects over the medial pterygoid muscle and attaches upward to the spine of the sphenoid, it thickens substantially. This thickened band drops down to the lingula of the mandible, creating the suspensory sphenomandibular ligament.
Question 5. Which nerve joins the lingual nerve in the deep face to provide special sensory taste fibers to the anterior two-thirds of the tongue? Is it A, mylohyoid nerve, B, chorda tympani, C, Leicester petrosal nerve, or D, deep temporal nerve?
The correct answer is B, the chorda tympani. A branch of the facial nerve, the chorda tympani, emerges at the spine of the sphenoid and physically joins the lingual nerve deep to the lateral pterygoid muscle, using it as a highway to reach the tongue and the submandibular ganglion.
And finally, question 6. Just before entering the mandibular foramen, the inferior alveolar artery gives off which specific branch? Options are A, mental artery, B, incisive artery, C, middle meningeal artery, or D, mylohyoid artery?
The correct answer is D, the mylohyoid artery. Just prior to diving into the bone at the mandibular foramen, the inferior alveolar artery sends the mylohyoid artery down along the mylohyoid groove to vascularize the mylohyoid muscle in the floor of the mouth. The mental and incisive arteries are terminal branches that arise only after the main artery has traveled through the mandibular canal.
Here are the details of this episode.
Deep face, the engine beneath expression. Byline. Where force is forged, movement is orchestrated, and the quiet machinery of mastication comes to life.